Thank you very much. Thank you. It's a big opportunity to me today be here. So I have no several conflict of interest statement to declare. As we well know, recent development in radiation oncology for breast cancer show a fast move towards a de-escalation strategy for breast cancer in early breast cancer, including accelerated and not partial breast irradiation. And what we have learned from major phase 3 trials, and the last years where we presented the RAPID trial and an NSABP 39 RTOG 0413 trial just published last week on The Lancet, and that if the disease control is closely related to the inadequate selection of patients for partial breast irradiation, the safety profile and the cosmetic outcome is more strongly associated to the technique concerns, technical choices. So the approach, the dose, the number of fractions per day, and the total dose. So the accelerated partial breast irradiation trial, Florence PBI MRT trial, is a phase 3 trial, a single center that enrolled between 2003 and 2013 520 patients, including that received breast conserving surgery, PT less than 25 millimeters, final surgical margins more than 5 millimeters in patients aged more than 40 years old, that were randomized 1-to-1 to receive accelerated partial breast irradiation using an IMRT technique, 30 gray in 5 fractions, non-consecutive is a schedule any other day, as compared to conventionally fractionated whole breast irradiation, 50 gray in 25 fractions, and a tumor bed boost of 10 gray in 5 fractions. The primary endpoint of the study was the ipsilateral breast tumor recurrence, and the 5 years results were presented here in San Antonio in 2014. At the time of this analysis, the median follow-up of both arms are more than 10 years, and every patient in every single arm receive a follow-up of at least 7 years. This is something about target delineations and quality assurance on our technique. It's a very easy technique. We need at least 4 mandatory surgical clips to identify the target, and the CTV was obtained by an isotropic 1 centimeter expansion, and the BTV it is obtained by another isotropic 1 centimeter expansion, limiting 3 millimeters by the skin and up to 4 millimeters intrusion toward the lung. These are the organs at risk that we contour, very simple: contralateral and homolateral lung, homolateral breast, contralateral breast, and heart, using these constraints. Coming to the results, to note the patient characteristics that will be presented this afternoon, most of patients were age more than 50, more than 90%, T1 tumor, negative nodal status, ER positive, and margins more than 5 millimeters. This is the primary endpoint. At median follow-up of 10 years, the 10-year cumulative incidence was 3.9 in the PBI arm as compared to 2.6 in the whole breast irradiation arm. Very low rate of events, 9 events at the 10-year in the PBI arm as compared to 6 events. That's a ratio is 1.57, p-value at 0.39. And just to show you the other local control outcomes, there is no difference, just 9 events as compared to 7 events in the local regional recurrence rate, so 3.9% as compared to 3%. And concerning contralateral breast cancer, to note, we observed just 2 events in the APBI arm as compared to 8 events in the WBI arm. It's less than 1% rate at 10-year cumulative incidence at 10-year for the PBI arm as compared to 3.5% in the WBI arm. Again, not significant. Concerning survival outcome, we had just 7 events each arm concerning distant metastasis, so the rate each arm was 3.1%, non-significant. As you can observe in the slides, there's a complete overlap also concerning breast cancer-specific survival and overall survival, where we observe for the breast cancer-specific survival at least 97.5% each arm as a ratio of 0.87, not significant, and the overall survival is basically completely overlap. Coming to the analysis of the adverse events, this is our results in terms of the acute toxicity as assessed by the RTOG and the OTC acute toxicity scale. As you can observe, we have very good results in both arms, but significantly in favor of the PBI arm. even if you consider any grade of toxicity incidence, any single grade, and grade equal or greater than 2. Late events, again, we observe very nice results, but in general terms, always significantly in favor of the PBI arm. If you consider any grade, if you consider any single grade, no grade greater than more than 3, or grade equal or more than 2. And finally, cosmesis. This is a crucial point since other trials have some concerns in terms of schedule adopted. We observe very nice results each arms. We use the Harvard-based cosmesis scale, so it's a cosmesis scale that evaluates just the effect of radiation therapy on cosmesis. So very excellent, good results, but again, this is the physician-rate cosmesis outcome, again in favor of the APBI arm. Concerning the patient rated, that's a difference, a clear difference, since patients are more self-critical, but again, we have more than 90% of good, excellent results, but again in favor of the PBI arm. Please note a 15% rate of favor results in the whole breast irradiation arm. So, coming briefly to conclusion, our 10-year cumulative ipsilateral breast tumor recurrence incidence rate in this early breast cancer patient treated with an external accelerated partial breast approach using an intensity modulated radiotherapy, this is a 5 once daily fractions in a schedule any other day, 30 grain, 5 fractions, is low, and basically not significantly different from patients treated with conventionally fractionated whole breast irradiation. We also observe comparable results in terms of local regional relapse, distant metastasis, breast cancer, specific and overall survival rates. Acute and late adverse events and cosmetic outcomes as assessed by patients and physicians were also in favor of the PBI arm. So basically this is just another piece of the puzzle, but we could consider that the PBI might be a standard alternative to WBI arm in very low risk early breast cancer patients. Thank you.